Thank you very much.
So if the speakers from this session could come up to the front, and we'll, as we did for the first session, open up the discussion for questions.
I wouldn't stay here, I think.
While people are coming up, we have 10 minutes for this, and then we'll break for lunch. And we'll be resuming here at 1:30. I am hoping to get a prompt start at 1:30. We have an exciting announcement, which I won't tell you what it is, so that you'll all come here at 1:30 to hear this. We'd like a microphone, just so that you know, all of these are being recorded, and the presenters we're recording it so that the slideshow is synchronized with the verbal part, and that will be available online. So you'll actually be able to see the slide talks and hear the discussion. But so everyone should use a microphone, otherwise it won't be part of the online summary.
I just want to ask the last speaker about the cost-effective analysis by region or by disease or by risk factor. What about calculating the cost-effective for a drug? For example, using Herceptin and breast cancer, and what would be the cost-effective? Because this is very crucial and important in low-income and middle-income countries.
Okay, so now I can look at you. Yes, of course, the cost-effectiveness of medicines is important as well. However, once we do the cost-effectiveness analysis of an intervention, you should know within each intervention, we go into the country, we talk to clinicians and say, okay, for which patient, what kind of drugs do you prescribe? What are the costs of those drugs? So within the costs of our cost-effectiveness analysis, all the drugs, etc., are taken into account as such. Whether Herceptin is cost-effective by itself, that is, of course, something that other people have already calculated as such in separate studies. That is not specifically redone within this cost-effectiveness analysis. However, all costs for the different drugs that are used are being taken into account when calculating a cost-effectiveness ratio in our study.
My name's Jill Donnelly, and I'm a breast surgeon from the UK, and I'm also here representing the Association of Breast Surgeons and the British Association of Surgical Oncology in the UK. I'd like to make a few points about ultrasound, if I may, and first of all, speaking as a surgeon who refused to be beaten by the knobs and pixels on the ultrasound machine, I can say that I certainly feel that ultrasound is the way to go in terms of the assessment of breast pathology in the settings that we're discussing, particularly in view of the fact that there is a very easy and low and very cost-effective workshop using chicken breasts, stuffed olives, and fluid in the fingertips of gloves, which can be inserted into the chicken breasts and used to mimic breast lumps and cysts. And these are workshops that I've put on myself, apparently quite successfully, in Palestine, in the West Bank and Gaza in the last 6 months, which are places where breast cancer is extremely common, probably similar to the Jordan figures that we saw earlier on. The second point that I would like to make briefly is relating to the early detection element of our initiative, and that is that I think we should certainly move away from the use of mammography, not only in low but also potentially in middle income settings, and concentrate very much on patient education, patient breast awareness in a local and culturally appropriate way, in the way that Beatrice and Anne presented very well, I think, this morning, and that then when women have presented with their local symptoms, we then use ultrasound to assess those symptoms. And if this is undertaken, actually mammography has very little role. One could also argue that in resource-rich settings, although that would be more controversial, I do appreciate. And just finally, I think a certain element of this will involve educating local medical professionals, because certainly my experience in Palestine is that we have a lot of breast cancer. What do they do in rich countries to detect it early? They do mammography. We must do mammography, and it's really opening a can of worms and is, in my view, hugely misguided. Thank you.
I just want to comment and say thank you for your support. And Ben, obviously, one of the things we need to do as a result of this conference is to find out who's putting on courses. I knew there were international courses going on. Polly's here, and this one and others. So one of the things, if we can all collectively get together, and Ben talked about a little meeting we're having Thursday, I guess it is.
Friday, I think at 3:30.
No, I think it's, I thought it was Thursday, but maybe not. Anyway, we'll get together informally and start to get together a list of who's teaching where and what and how.
Let's verify. We thought you said Friday, but anyway,
No, it's,
we'll
it's
talk
Thursday, I think. Yeah. Thank you, Lorraine.
Okay, Naji Al-Sagir. Thank you, Dr. Harness. I have a suggestion. I want to question and a suggestion. There is a practical issue that we will have to deal with, when we're recommending this for countries with limited resources. When you have an ultrasound done, it has to be, of course, by well-trained, well-trained individual, like you mentioned. But then it has to be under the supervision of a radiologist. We struggle. I work, in Lebanon, and we do struggle to have very good ultrasound of the breast. Even we get ultrasounds read by other radiologists. We say, no, I would rather have it read by a breast ultrasonographer. And who will sign out the report? And you have to have some regulations as who can perform and read those ultrasounds. Because as a resulting of that, biopsies, no biopsies, lumpectomy, no lumpectomy. So it has big implications. So this is a practical issue that we have to deal with, to license people to do that.
Yeah, I don't disagree at all. And those issues will vary from setting to setting, country to country, need to be dealt with locally and appropriately. One of the things I've said for 15 years, and I'm going to say it again today, I am not in competition with breast radiologists. I primarily use ultrasound as an adjunct to the physical examination and to guide other things. And yes, I do have the ability to do biopsies and what have you. Our American Society of Breast Surgeons has looked at this issue. We actually have an accreditation program in breast ultrasound as an example. But you're correct. These issues need to be worked out at the individual geographic location.